Good afternoon. My name is Dr. Clement Nguka. I'll be wrapping up today our drug-resistant TB. And the drug-resistant TB that we have discussed so far is for patients who are more than 15 years, from 15 years upwards. We're not doing those who are less than 15 years because that is regarded as a pediatric community or a pediatric population. And that one is treated at a specialized center, that is the Center of Excellence. In our case, in South Africa, it's Sizwe Hospital. That's a Center of Excellence. So they deal with the pediatric population. Now, so what we have been talking about all along has been those who are greater than 15 years. Right. Now, the most important thing that you need to take home is, how do I treat? We have already analyzed this. We have said all patients whose HB is greater than 8 grams per DL, all those patients they qualify, for instance, to be treated for that's number one. They qualify to be treated using what we call with these patients, there's this differentiation that is so crucial. It must be a patient who doesn't have extrapulmonary TB, the severe extrapulmonary TB. We have classified it already, that those patients will be treated using an individualized regimen, an individualized, DR regimen. And all patients, once they test positive for drug-resistant TB, we always use this criterion that we want people to, it's a molecular technique known as the gene expert, and we say it looks at an RPOB gene, which is part of the genome of Mycobacterium tuberculosis. If it is resistant, then we start asking ourselves, is the HB less than 8 grams per GL? If it's less than 8 grams per GL, we are in trouble. We have to say, we're going to treat this with individualized regimen. We're going to send this patient, we are going to hospitalize this patient for blood transfusion or something like that. We're going to do that. We're going to do that. Or if the HB is greater than 8 grams per GL, we're going to say, this is our patient, for BPAL-L. What did you say BPAL-L is? Remember, this is to summarize and wrap up a drug-resistant TB. What is this BPAL-L? We said BPAL-L means B for pedunculate. PA, that's your predominant. And then L for linezolid. -L, the other L, the last L, is for levofloxacin. That's crucial. It is important to say, am I here or I'm doing severe pulmonary TB, extrapulmonary TB? If it's severe extrapulmonary TB, I forget about BPAL-L. If it's BPAL-L, what am I looking for? What am I looking for? I'm looking for the mutations of INH. If there are 2 mutations of INH, We've got INHA, which is low dose, as we said, low dose mutation, which you can easily solve. We can easily solve by increasing the dosage. We know that INH is always 300 milligrams and daily, and we can up it to 600 milligrams. The problem is solved because it was a low dosage. Now, if the lab says it is low dosage, I'm going to give my B-pal-DHL. That's important. It's a determining factor. When do I use B-pal-DHL? If it's INHA, I'm going to use B-pal-DHL. If it is CAT-G, I'm going to use, what is CAT-G? CAT-G, it's when you've upped your dosage. It's high dose mutation. That's a high dose. You must actually give it high dose. That mutation is called CAT-G. Please give your B-pal-DHL as if it was INHA. Give B-pal-DHL. If both mutations are there, in other words, INHA is there, and what is the other one? CAT-G is there. Those two, if they are both of them there, you still give B-pal-DHL. That is important to know. Because when you go down, you go to the others, if you have a fluoroquinolone that's actually sensitive. Which fluoroquinolone are we talking about here? Oh, we're talking about levofloxacin. We're talking about ofloxacin. We're talking about moxifloxacin. If those are, this is sensitive to. In other words, it's the result from the lab comes back saying sensitive to levofloxacin, sensitive to moxifloxacin, sensitive to any. Of course, the one that we're looking for is levofloxacin because that's the one that we're using. Remember, we said levofloxacin has got a low. You remember the QT interval, the prolongation of a QT. It prolongs the QT interval, but to a lesser extent than moxifloxacin. That is why we chose this one. Those are important considerations to be taken into account of. You need to know that I'm using levofloxacin because of that. But then now, if it is sensitive, I still use my B-pal-DHL. I don't have a problem. B-pal-DHL. Now, if, how do you pick up whether this Mycobacterium tuberculosis is like sensitive to levofloxacin, is sensitive to moxifloxacin, sensitive to afloxacin, okay? How do we pick it up? We use a special test. An XDR cartridge. It's able to do that. We're no longer thinking of the old stuff like the line probe assay, LPA. No, we're not thinking of that. We are going to get results for INH. We are also going to get results for levofloxacin, and using this new technique, this XDR cartridge. So if we get now, so if it's not functional, say you don't get good results, you don't know what's going on, what are we going to do? Are we still going to continue with our B-pal-DHL? Yes, we are. If we get results which, inconclusive results, go on with B-pal-DHL whilst you're investigating with the lab. Go on, B-pal-DHL. When do you stop using B-pal-DHL? You stop using B-pal-DHL whenever you get a result from the cartridge or the XDR cartridge that says levofloxacin is being resisted. If levofloxacin is being resisted, how do you continue the B-pal-DHL? You can't. You need to go on now with B-pal. not Bpal dash, the dash L, you throw it away because it's being resisted. Now, that's the importance of the cartridge, that is XDR cartridge, because it will give you that result. It will say it is resistant, and if it is resistant, it tells you now for sure that I must go for Bpal. I'll use bedaquiline, I'll use predominate, I'll use levofloxacin. No, man. I'll use linezolid instead of levofloxacin. Understand? That's very good to know. This is a take-home message. Take-home message. When do you use Bpal? You use Bpal only when the XDR cartridge says levofloxacin is being resisted. How do you forget about this Bpal-L, Bpal? How do you forget about it? I forget about it. As I said, I'm wrapping up now. You forget about it whenever you have severe extrapulmonary TB. When do you have severe extrapulmonary TB? When I have TB meningitis, CNS disease. When I have that, I stop. I cannot go on with Bpal-L. When I have TB pericarditis, you need to be able, first of all, to diagnose the pericarditis, to say that this is a pericarditis. That's often challenging to healthcare workers. You have to go a little bit into the ECG analysis. And so do you see the importance of doing an ECG as a baseline test? Because you need to establish the fact that, do we have TB pericarditis or not? TB pericarditis. Because TB pericarditis tells me that go for individualized regimen, long regimen. You remember the Bpal-L is a short regimen. So the individualized, it has to be individual long regimen. Then that one, you're going to discuss it with the top guys. You're going to talk to provincial, clinical, clinical committee. They call it a provincial clinical advisory committee. Yeah, that's what we call it. If you fail with that, you've got to go to the national clinical advisory committee. Go to those people are going to help you. The one that I use on a daily basis is the Center of Excellence. Center of Excellence, they're very helpful. That is Sizwe Hospital. You talk to those doctors, they're aces. They know exactly what they're talking about. They know exactly what they're doing. That's a Center of Excellence. That's where even the pediatric population is being treated. This is what we need to know. We need to take that up. What else? You know, I don't want to forget this extrapulmonary, severe extrapulmonary. When do we regard a TB as being as severe extrapulmonary? We regarded it, we said CNS disease. In other words, TB meningitis. We said TB pericarditis. We said TB osteoarticular. That's bone disease. You know, like, I don't want to think of my patient who had a TB spine. Couldn't walk. Don't want to think of patients like that. Because you need to go for individualized long range. Abdominal TB. Those patients with distended abdomen, you know, they've got an ascites, and then if you pull the fluid, it's test positive for. Well, we've had a patient testing positive for RIF resistance. RIF resistance, but it's an abdominal TB. If it's an abdominal TB, that rifampicin resistant. In other words, the RPOB gene is resistant. It has got a mutation. The RPOB gene is so it's resistant. So you know these mutations, they cause resistance. This is what we need to know about drug resistant. One day, I'll come back with drug-resistant TB in the pediatric population. But I don't want to emphasize this one much, because it belongs to the Center of Excellence, Sizwe Hospital. They are the ones who can use the delaminides and the rest. You know, all those high drugs, you know, sophistication. You know, sophisticated. That us at a primary healthcare level, we don't use delaminides and all that. We don't. But I need to wrap up by saying, you know, if you have INHA mutation, there's cross-resistance between INH mutation. And, you know, we have to think this. With all the drugs which have cross-resistance with INH mutation, we have to use our PPAL-L. If you've got cross mutation, in other words, you get a drug that is resistant because there's INH mutation. That drug has got still, you continue with the PPAL-L. You regard it as INHA. You regard it as INHA. So if you get some cross resistance, then one has to think of PPAL-L. But otherwise, all that, you know, if you think of disseminated TB like miliary TB, that's severe extrapulmonary. That patient has got to be treated with an individualized long regimen. And patients like that, we don't treat them at primary health care. We always refer those patients to the Center of Excellence, like Sizwe. We always refer those patients to the provincial clinical advisory committee. We always refer them to the national. If we can't get the provincial, we get to the National Clinical Advisory Committee. Thank you very much for listening to me talking about drug resistance. If you have any questions, maybe you should jot them down, send them over to me. I'll make all the efforts to respond to those questions. Thank you very much.